So I'm going to really set the scene, if you like, by talking about our goals of therapy in type 2 diabetes. My name is Gary Kilov. I'm a GP. I practice in northern Tasmania, and it's just wonderful to be up here in the warmth. It's lovely. And with that, I wish to give you a warm welcome, not only to those people in the room, but those who are joining us remotely. There are people who have logged in and have a virtual presence around the country. So to those of you who are on your devices at home, welcome, and please, we would like you to submit some questions as well, utilizing the same format. So diabetes, as you know, is a disease of glycemic dysregulation, a chronic, persistent, and progressive hyperglycemia. We're talking about type 2 diabetes this evening, and so we know that despite the fact that hyperglycemia is what defines the condition, whether it's an HbA1c, an oral glucose tolerance test, a fasting glucose, random glucose, if any of those are elevated and they fit the criteria for diabetes, that's what gives us the diagnosis. But thankfully, rarely now do people actually succumb to the acute effects of hyperglycemia. It's the chronic toxic nature of hyperglycemia on blood vessels that causes the adverse outcomes for our patients. So these adverse outcomes on large vessels, macrovascular disease, will result in 2/3 of our patients succumbing to a cardiovascular event. And it's not just that individuals will get these events more readily than people without diabetes. In other words, it's not just the morbidity, but there's also mortality, significant mortality, which results in loss of life. As an example, let me show you what happens if you happen to be a 50-year-old male with diabetes who's had a myocardial infarction. You will lose 15 years of life expectancy. If you're a 60-year-old, diabetes, myocardial infarction, you will lose more than a decade. And the prognosis for women is even worse. A 50-year-old person with diabetes and an infarct will lose almost 2 decades of life expectancy. A 60-year-old, 15 years. And you know that in terms of prognosis, this is worse than many of the cancers that we deal with. In addition to being toxic to large vessels, diabetes is toxic to small vessels, microvascular disease, and one of the concerns, one of the manifestations of this microvascular disease is chronic kidney disease. And again, you all know that diabetes is the leading cause of end-stage kidney failure, with around 1/3 of our patients developing CKD within 20 years of diagnosis. And to add to the toxicity of this mix, microvascular disease of the kidneys, so chronic kidney disease, is in itself an independent risk factor for cardiovascular disease, which, as I showed you before, is pretty nasty in the setting of diabetes. So, given that hyperglycemia is bad, does reducing blood glucose mitigate some of these adverse outcomes? Well, the answer is yes and no. For microvascular disease, we have good evidence, robust evidence, to show the benefits around a 25 to 30% reduction in microvascular endpoints for each 1% reduction in HbA1c. But consistently and disappointingly, we have found that intensive treatment versus standard care has been disappointing with respect to mitigating macrovascular disease or cardiovascular disease, both events and mortality. So the question is, does treating elevated blood glucose to mitigate cardiovascular disease, is this an exercise in futility? Are we wasting our time? Are we using expensive medications, subjecting our patients to side effects for no benefit at all? As much in life and much in medicine, it's complicated. And our panel of speakers will simplify that for you. Because as it turns out, it's not so much about reducing blood glucose as how you go about achieving that reduction. With that, it gives me enormous pleasure to invite Dr. Marwan Obaid, who's an endocrinologist, to really start providing you some of the answers to my provocative questions. Thank you.